And so I'll say that one more time because the recording just happened. So buenos dias, everybody. Thank you so much to Dr. Pendergrass, as well as Giselle Hernandez through the Faculty Advancement Office for giving us a platform for our Community Engagement and Health Equity Office to connect with faculty as well as students and trainees. And so if you haven't been here before, the series really happens once a semester and really focuses on opportunities for faculty and students to leverage our office and the resources we've provided. And so last year we talked about service grants, and I will just highlight again, if you're interested in potentially working with my office in terms of service grants that would be beneficial for you, also would be public health practice and focused on outreach and engagement, please reach out to me. In addition to that, what we are going to talk about today are some data sets that we have that we so desperately want folks to use and leverage. And so today I'll talk a little bit about our community health needs assessments and opportunities for faculty as well as their trainees to get involved and have access to data and publish, use it for grants. And the idea, right, is that the more that we use these data, then the more benefit and the more recognition we give to the residents who've completed it across the years. Because if we have data, but the data stay stored and locked and not used, then we do a disservice to our communities. So what I'll talk about today is I'll give you a little bit of background around the community health needs assessments and what we have. I'll then talk through what our data elements we have across years for folks who might be interested in longitudinal analysis. Some of the new data elements that we got in 2023. We'll give you a little bit of the sample characteristics as well as analytic opportunities. And, essentially end with, if you're interested in exploring a partnership where you get to produce a paper or get some pilot data that would help for a grant of any kind, then you can, the steps to reach out to us around that. Okay, so here is the background. Really briefly, similar to other cancer centers, our cancer center is tasked every 2 years to do community health needs assessments. And the goal of these community health needs assessments is to really identify what are community priorities that our science at the cancer center should do. And so we do it every 2 years, and then it aligns with our strategic planning process, which is every 5 years, wherein we have 2 cycles of resident information. We can do assessments in terms of any shifts in priorities and shifts in needs. And so our assessment incorporates or considers 2 strategies. One are quantitative surveys to identify needs and priorities. And so these are the traditional quantitative assessments that you would see, which would include self-reporting on personal health, history needs, on perceptions as to what the cancer center should work on, and things of that nature. And it's usually done with residents through a convenience-based sample. And that's what today's focus will largely be in. I do want to highlight that starting 2 years ago, and then we'll be doing it again this year for 2025, we've also started doing complimentary qualitative listening sessions. Those are very similar to focus groups, not necessarily focus groups, but they do allow for opportunities for us to connect with community leaders to identify assets and resources. So specifically, what are partnership opportunities that we can connect on? What are ways in which we can work together in the coming years? And I want to just give a shout out to my boss, Deidre Reese, who is the director of a Community Engagement and Health Equity Office, because this was definitely a major contribution of many contributions she's given our office, and specifically the community health needs assessments in the past few years. I wanted to say thank you, because I think this really allows us to not only consider what might be priorities from the resident level, but really also understand what is the infrastructure that we're embedded in and how can we move forward. I want to just also give a quick shout out to boss Jeanette, who drove me really quickly to this meeting because I was giving another talk in Little Village, and who's really been leading the charge with these community health needs assessments for 2021, 2023, as well as 2025 now, as our associate director for our community engagement and assessment branch. And so really briefly, now that you've kind of got a little bit of context, the good part of this needs assessment is that it's conducted every 2 years, and we started in 2019. So for example, if you are interested in looking at pre-post changes due to COVID, you can assess that with our data set. We have 2019, 2021, 2023, 2025. And I think listening will come up in the future, slides, but we have, I believe, about 500 to over 1,500 respondents for each year. So it's a pretty good sized set of samples that can help us with thinking through any population shifts and priorities and needs. So here are some data elements that will be available. And so I'm going to highlight again the longitudinal data that we have, and then I'll note the specific elements that we introduced in 2023, and we'll go from there. So of course, we typically assess people's demographics. That's age, race, ethnicity, gender, employment, zip code, and insurance. And what I want to highlight to you all there is that because we have zip code, we have the ability to augment the residence data set with neighborhood level characteristics. So if you're interested in multi-level data analysis, you could theoretically link by zip code and then assess things such as, what do residents from persistently impoverished neighborhoods want us to study versus individuals in other neighborhoods. So that's just one idea as to what you can do. We also, across the years, have access to people's healthcare ability. We have access to healthcare access in the sense that we have continuously asked whether they have a primary care provider, a dentist, and then gynecologist. In terms of cancer, we do ask cancer history as well as family and friend cancer history. And then we do have personal self-report data on mammography, Pap tests, prostate cancer, HPV vaccination, and colon cancer. So again, this is from 2019, 2021, 2023. So you can really see some shifts. And what I will say is this is a good complement to what we have at the population level in terms of more representative samples. And I'll show you in a little bit the sample characteristics, but we have some really helpful data to kind of give insights around how potentially someone's cancer history or someone's status in terms of their cancer screenings, how that dictates what they think is a problem in their community. So then we also have data on interest in cancer screening. So interest in learning more about cancer screening and or taking and getting cancer screening. And that's for breast, cervical, prostate, as well as colorectal. Probably our main outcome that I would say is really helpful and important is the three things that impact your community. So I think of this as the primary outcome for our cancer center in that we, again, are using the community health needs assessments not to assess people's behaviors and health, but really what they believe and what they endorse for us to do as a cancer center. And so we have enabled them to ask, essentially let us know what are three health problems. That doesn't include only cancer. So for those of us who are interested in social determinants of health, who are interested in other chronic conditions, as well as in some infectious disease, we do have a wide reach of the different health conditions, and we'll show you a little bit of it later on. And then if you're interested and want to know a little bit more, then I'm happy to share the data instrument tools with folks who are interested. So then the final piece are the barriers to healthcare, which are transportation, cost, and trust that have been measured across years. And so giving you just a brief example in terms of how these data sets have been really helpful. We, a couple years ago, analyzed pre versus after COVID assessments in people's barriers to healthcare. And so what we saw, of course, is that cost and transportation, these like economic and structural barriers, increased after COVID. However, trust and knowledge as barriers decreased as barriers. And so saying it again in a different way, what we see pre versus post-COVID with these data sets, and this hasn't been published yet, so if folks are interested in exploring it, happy to collaborate in that way. But what we essentially see is a reduction in psychosocial barriers to healthcare, while we have an increase in healthcare access and structural barriers because of the pandemic. So something to be thoughtful of, keep in your mind in terms of opportunities and publication ideas. So then I want to introduce you all to what we started collecting in 2023 and are going to be doing again in 2025. So after this summer, there will be an opportunity for assessing some change across 2 years, and there'll be an opportunity for stacking data sets. So if you want to just stack the 2023 respondents with the 2025 respondents to really get at these questions, you'd be able to do so. And so these questions are really important to me in the sense that when we ask people what are health problems in their community, what we don't ask is what is the role of our cancer center and what is the role of academics, right? And so I think that so often we have these strategies and these solutions and these interventions, but we don't get community feedback as to what would be the most important intervention to employ, right? And what that usually involves is us doing focus groups and really restricting it in terms of our capacity. And so what we end up happening is a fragmented landscape in terms of scientists connecting with community, and everyone's having a focus group around what strategy would be best. And so my dream and my vision for the community health needs assessment for our cancer center is really to do a broad landscape, right, in terms of community residents and what are topic areas that they want us to pursue, and allow for kind of that broad survey to be helpful for figuring out what kind of research or what kind of partners we can connect with in the future. So in terms of that, we have 3 questions that we started asking in 2023 that we're going to be repeating for 2025. One is, what is the most important topic that scientists should study to help prevent cancer in your community? The second is, what is the most important factor that scientists should study to develop better treatments for aggressive and fast-growing cancers? And then finally, what are the most important types of treatments and medicines to develop cancer? So what I'll note with all 3 of these is they are not open-ended questions. There are different response categories that exist, which we'll show you in a little bit. And the response categories, or the answers that they could have selected, were based off of conversations with community leaders on our community advisory board, as well as our scientific leaders through the University of Illinois Cancer Center. And so that's how we came up with the response categories. We have used the same ones in 2023 and 2025. There is potentially a chance to add more response categories in 2027, I would say, as is of interest, and if you want to kind of pursue this in the future. So let me show you a little bit of who we connected with and who's been endorsing what we should be doing as a cancer center. And so these are the demographics across the years. And so what you see here is that the mean age is about 47 years old, but we have a good range from 18 to 90 years old. What you'll notice here, and something that is definitely something for us to be proud of, is that populations who have been historically undersampled in terms of representative are very well represented in our community health needs assessment. So across the years, primarily we have a Latina and African American or Black response rate, if you will. Then, not surprisingly, of course, we have about 80% of people participating being women. That said, 20% is pretty good, especially if you think about it in terms of the average sample size, right? Being in the hundreds to the thousands, 20% becomes reasonable in terms of doing any power analysis that you'd like. Last year, 2 years ago in 2023, based off of one of our CAB representatives' feedback and advocacy points, we started collecting data on veteran status or participation in the US military. And so what was helpful is that we have seen that the areas wherein we have been working in terms of community health needs assessments has relatively few veterans. And so it's good for us to know it's something that we're championing for 2025 in terms of making sure that we have a little bit more representation. Just for thoughts, I believe, and of course this is being recorded, so I can't wait for this to be in there, but I believe that we see about somewhere between 8 to 11% of the Chicago land area identify as veterans. So there's definitely a little bit more that we should be doing in order to get that representativeness there. In terms of disability status, which we have collected across years, we have about 14% of individuals who identify as having a physical or cognitive disability. And then, as you can see here, we have a rich diversity in terms of educational attainment, wherein about 45% of the sample have less than high school, and then others have varying ranges of high school degrees all the way to having doctoral degrees and the like. Perfect. Okay. So giving you a little bit of a flavor in terms of what we found the last year in terms of our cancer risks. And again, we do have information in terms of exercise, diet, and tobacco use across years. We're focusing on 2023 right now, just for data cleaning purposes. But so you can see kind of what we got last time that we distributed this survey. What we see is that about 21% of our sample reported either no exercise, poor diet, or tobacco use. And then among them, we have about 15% who reported no exercise or poor diet, and then about 11% who self-reported using tobacco. So this is a nice, reasonable group, if you will, or proportion for kind of thinking through what are predictors of these behaviors, but also thinking about how these behaviors potentially influence what community members think we should assess. In terms of reported cancer screening history, we have about 40% of the sample who self-reported getting breast cancer screenings as recommended. So I believe it was breast cancer screenings at least every 2 years. Cervical cancer screenings, which I believe were every 5 years, but I can go back and confirm on that. And then colorectal cancer screenings, where we ask questions for both stool-based kits as well as colonoscopies, and then we coded them to be in line with the different years or the different frequencies based off of the cancer screening test. And so you can see about somewhere between 30 to 40% for each of these screening types, which again allows for a lot of opportunity in terms of comparing how people who are able to meet the recommendations versus people who are not able to meet the recommendations, what they prioritize in terms of their community health problems, how they prioritize cancer, and then how they prioritize the kind of science they want to see. So something to also highlight there, we have about 30% of our respondents who reported having any type of personal or immediate family cancer history. And what I think is really helpful about this is that it can, of course, also highlight the differences and perspectives of survivors, of people with a close connection versus those who do not have a connection. And I keep bringing this up, but all of this is really critical for really understanding what drives potentially people's perceptions of what our community, what are problems for their community, and also what are scientific advances that they would like to see. So in terms of our sample characteristics, just for folks to see there, we have, in general, a really good representation of South and West Side communities. These, I believe, are data that are representing specifically more of the West Side pieces, where we have, for example, 31% of survey respondents coming from Austin and about 20% from Humboldt Park. I will say this is definitely weighted based off of what we did one year, the 2021 survey year, where we were definitively very focused on the West Side for a community health needs assessment that was started for a project that the Cancer Center then leveraged for the larger Cancer Center. And so with that in mind, we're happy to show percents and other data that really highlight the South Side representation. With that said, definitely we are more on the South Side and West Sides of Chicago, or we have been historically. We have tried to branch and have some data in terms of the Western suburbs as well as the Southern suburbs, though it is ever a growing experience. And Deidre and Jeanette are working really hard to maximize our representation across Cook County. Okay, so here are some data just so you can kind of see what's going on through there. We have, for example, in terms of cancer being a community priority, about 26% of residents reporting that cancer is one of the top 3 issues that we need to address. And then in 2023, we started asking them about the specific cancer types. As you can see here, breast is definitely one of the running priorities. It's understandable given that women are the ones who are largely completing these survey assessments. And then we have prostate cancer and lung cancer, a little bit of colorectal, and then a little bit of liver cancer as well. And what's nice about this is these are the 5 cancers that are priority cancers for our cancer center and for which we have robust data in terms of representative data for screening rates for stage of diagnosis. And so, for example, what we know for our catchment area of Cook County is that there are disparities in liver, late stage of diagnosis for liver, as well as mortality, as well as incidence for Latine, as well as African-American populations. And then similarly, there's a bit of differences in terms of populations for the other 4 types of cancers. So in case you wanted to see kind of what people wanted to learn about in this space, you can see here, these are changes in terms of focus on breast cancer versus HPV and cervical cancer versus colorectal versus prostate. And you can see in 2019, this is what we saw in terms of our convenience-based sample, wherein there was, I would say, relatively low levels of interest in any of the cancers, maybe the most for cervical cancer and HPV. And then in 2021, we've seen a kind of a shot up in terms of breast cancer, if you will. We actually see a little bit of a dip with HPV cervical, but it may be just dependent on, there might be different factors going in there. And then we see a growth in 2023. In terms of colon cancer, we see a nice steady increase in terms of interest in colorectal cancer. And then similarly with prostate cancer. So a growing amount in there. And so this aligns with some of the work that we have seen regarding, again, what were changes after COVID that influence people's interest in learning more about cancer screenings. Okay, so there are a number of scientific priorities that we've been able to report out on in 2023. The first question, so remember we had these 3 questions we started last community health needs assessment. And the first one was, what should future prevention research focus on? So again, these response categories were really based off of what community as well as our scientific leaders wanted us to measure. And so what we see is that about 43% of community health needs respondents want research to address lifestyle and how lifestyle affects cancer risks. And then about 39% wanted strategies and interventions around the contributions of genes or family history for cancer incidence, right? And thinking about that in terms of prevention research. Then about 32% wanted us to focus on environmental level factors and neighborhood level factors. Then about 6% had other, which I'm happy to report out on if you have interest in terms of talking it offline. So what you can see here is really, and this may be helpful, especially if you're a researcher or a student who's invested in lifestyle, as well as in genetic contributions to disparities. What you can potentially leverage this data for is really understanding who is endorsing the importance of lifestyle intervention, who is endorsing the importance of thinking through the role of genes, right, in health equity and in health promotion work. And so what's nice about this is if these are of use to you, they can be potentially helpful in terms of a grant that you would be wanting to write. It would also be helpful in terms of publications as you want to explore a little bit more around what communities perceive to be the strategy that they want for preventative cancer research. I will also highlight that we, of course, address screenings research, which was the second question that we brought up before. So we had 3 types of screenings that were elected by our partners, academic and community. One was finding multiple cancers at once. So these are for folks who are interested in multi-cancer early detection tests. This one was informative for us exploring and continuing on our interests for MCEDs. Then also screenings tailored to your risks. So this was really in line with precision medicine. So thinking about screenings and when you should do screenings based off of your family history, your environmental health, and your lifestyle factors. And it was spelled out a little bit more for residents so that they could understand what we were asking there. Then screenings by yourself was also a top priority for that in terms of screenings that you could take home. And what's really interesting as we've done some sub-analyses in terms of neighborhood, for example, is that individuals who are in medically underserved areas tend to have a slightly greater interest in research that would be home-based screenings, for example. And that might make sense given their access and transit challenges in getting that kind of screening in clinics that are outside of their neighborhoods. So then I will show you a little bit more in terms of community priorities. So this was future treatments research. And so what is the kind of treatment that they want cancer center scientists to work on? And so what you can see here is that lifestyle strategies to prevent cancer was definitely the top priority there. And then medicine to prevent cancer from starting followed through. So as you can see here, a lot of it concerns really prevention and preventative work, which aligns with what we hear anecdotally as well as with robust qualitative data. We do have some information in the context of treatment. So specifically medicine with the fewest side effects definitely is stuff that it is important relative to medicine that patients can take home, right? Such as, infusions if we're talking about chemotherapy at home. Really the goal is as few side effects as is possible. And then medicine tailored to your risks or medicine based off of your medicine that's personalized was also one of the identified priorities. So then we focus also specifically on aggressive cancers. And you can see here again, it aligns with some of the data from just treatment in general. But really, again, with the focus that we need to be investing in lifestyle interventions, as well as thinking through maybe lifestyle interventions that are tailored based off of family history. As you can see here, there are some light differences. I wouldn't say significant differences, but some differences in the context of community geographic differences and what research should focus on. So for example, if you want to look at it, we see that in general, folks are prioritizing prevention trials, but specifically in South suburban communities, and those respondents feel strongly about that relative to West suburban communities. And then in terms of screening trials, it seems relatively consistent or robust, as well as treatment studies, with the note that West suburban respondents were slightly less interested in treatment trials. So I've given a lot of data, and I want to leave a lot of room and time for folks to ask any questions, but I want to just highlight there similar to what I started the conversation with. We are very interested in partnership with faculty. We're very interested in partnership with students who have faculty mentors in terms of leveraging these data. A lot of what we're doing is for institutional awareness and institutional direction, and making sure that our investments at the Cancer Center are really directed by community feedback. That said, we have a lot of data, and as I said before, the best way to respect and honor and celebrate people who've completed these surveys is to use them as much as is possible and use that to really advance our science in general. And so we're really excited to offer these opportunities. The data are free. We do have a team who can help with data cleaning, and then also a team who can help with data analysis as is helpful. And so if you are interested and you have an idea, also if you are interested but you need to look at the assessments more, feel free to email a broad idea. It can be one sentence and say, I would love to hear, here's what I'm interested in. Here are the data sets that I would like to explore and see. And so the idea is you'd email me, and we'd schedule a meeting with the CHNA team, which would include myself, potentially Amina Abdullah, who's our Associate Director for Community Engaged Research, for Research and Advocacy, and then Julia Piñeros, who is the person who's been helping a lot with data cleaning and management. So email, schedule a meeting, and then we would work together in terms of coming up with the idea, working together with it. And then ideally, we would be represented in the authorship for the presentations and the manuscripts. And we would also know if you're, for example, using these pilot data for an external grant or for an internal grant, it'd be helpful for our purposes, right, to understand how you're using the data and what the outcome was if you use the data for your grant. So with that, I definitely gave a lot of information. What I'm going to do is just put my email in the chat, because that is always the first call. So if you want more information or you want to just kind of sit down and have a conversation, you're welcome to email me. I will say that probably if I'm not available, we have a robust team who are very excited to connect, right? And so we'll meet with you probably within a few weeks of you setting up the email, and then we're happy to share the data elements with you before the meeting. So if you want to email, look at the elements, and then set up a meeting, happy to do it. And that was in record time. So now we have 25 minutes to hang out. I'm going to take my phone unapologetically downstairs so I can grab the coffee as I was running the door to be on the screen. So you'll see me moving downstairs and then upstairs. But yeah, excited to connect. Really would love any questions or feedback that will be helpful for partnering.
Yami, I had a quick question. This is Jeanette. In terms of the scientific priorities that we list in the community health needs assessment, who decides which ones we're going to list on there? Is it based on that we know that we have something coming down the pipeline to address these, or how do we determine those that we listed in the community health needs assessment?
Yeah, absolutely. So our community advisory board, along with our scientific leaders, so those are the associate directors and program leaders for cancer prevention and control, translational oncology, and then cancer biology also has been involved. They launched the initial one in 2023. And so they gave, here are the types of research that we think would be important for people to weigh in on. I will say that ideally, we can have more response categories. The reason why I would say 2027, not 2025, is that we've already launched for 2025. As you know, because Jeanette, by the way, was with me at this community event where all of these surveys were already being answered and completed by a robust group of Latina identifying people who are Spanish speaking, which by the way are somewhere between 20 to 40% of our sample, depending on the year. So cutting it even more quickly, for those folks who are interested, if you're like, I love this, I would love this in the future, and here's the kind of question I have, you can offer, here are categories that would be helpful for us to think about in the future. And then what would happen is we would take it back to our community advisory board and our scientific leaders, and then we'd let you know. So this is a little bit like births in that you can nominate, you can give questions to be considered for the future years. We may take it, we will definitely know if we do, and you'll definitely know if we don't.
Hi, Yami. Thank you for walking us through this. So I know that you mentioned cancer came up as one of the priority areas for the community. Could you also mention what the other top priorities were?
Absolutely. So substance use is definitely one that consistently comes up. I would say substance use probably is one of the biggest ones. And I know this is not just because you're asking, Mayra, but like I would say substance use is definitely a top one. I think the other ones that have come up are heart disease as well as diabetes. So for folks who are interested in other chronic disease, those are probably the ones that I would say are the top picks, if you will.
Yami, really quickly, thank you for this excellent presentation. In terms of in the needs assessment, is there any information or data elements around hospitalizations or primary care providers? Or I know you asked about specific ones, but are there any information about, obviously, I'd be interested in our emergency department usage or any of that stuff. I know in past there've been, we kind of get at it, but I'm not quite sure if that is a specific data element, anything related to hospitalizations.
Unfortunately, I believe we don't have it. We might have had it in 2019. I'll look back and I'll let you know. But again, I think definitely, especially our growing partnership, right, with your leadership, right, in terms of the Cancer Center and emergency medicine, I think we should add it in there, especially because we have some specialists, but not all specialists, right? So I think that would definitely be important.
This is great. Thanks so much for presenting this. I have a question about cancer history. Do you know have you guys roughly looked at who has, or like what percentage has a cancer history in this, at least in the 2023 data?
Yeah, I know. Should be able to pull it up. I want to say it's somewhere between, I want to say it's about 15% in terms of personal history is the piece. And then the 20% is kind of spanned across years, but I think we have at least 15%. And then I think if we add all of the people of personal cancer history across, like, so if you want to stack it, I think that we would be able to get into the hundreds in terms of folks who are self-reported cancer survivors or people with cancer diagnoses.
Gotcha. And then for just one more question, with the lifestyle, do you, for that as a scientific priority, do you have that broken down by behavior, or did you kind of just broadly ask about lifestyle behaviors?
Yeah, thank you. We separated out tobacco from diet and physical activity, but we combined diet and physical activity.
Okay.
The last year we did a little bit more, so I don't have the full scope with me, but we also calculated cardiometabolic risks. And that was based off of personal history of, let's say, hypertension and diabetes, and then also adding in physical self-reported behaviors.
Great. Thank you.
Yeah.
I have a question. And thank you for this great presentation. This is my first time hearing of this data, so I'm still trying to get my head around like what kinds of questions might be able to be asked. But I do have a student coming in this summer working through the Cancer Center, and I'm just wondering, just brainstorming out loud here, is that something that perhaps we could propose a project and have a student work on this with us? Okay.
Absolutely. Yep.
Okay.
There has been one team, because I've tried to make this offer, but I will tell you it's always a lot to kind of process and get in. So we do have one team who's actively working with our data set this year, and their student is the one who's leading the analyses. And so what's nice is, or to give you like an idea of the supports, what is helpful is that we have Julia Piñeros, who's got an MPH. So she can do the basic data cleaning, but she can also help with analysis, right? In case, just depending on your students' like comfort, right, and access to analytic skills. We do have someone on our team who can provide that help and that support, right, in terms of basic descriptives, showing the tables. And then just so you know, we've been kind of going back and forth around this. There's always a challenge, right? Because if we share the data set, we don't know who ends up getting the data set, right? So what we prefer to do initially is kind of hear what you have, give you some preliminary data. And then if there's analyses that really are out of the scope, right, of Juliet's space, and then out of the scope, my scope, if you will, then we can have a conversation around a tailored data set, and we'll have a data use agreement for that.
That makes perfect sense. Okay. I'm one of Sage Kim's postdocs, so let me have a conversation with her and let me get my head around this and see how we might be able to work with
You let Sage know, because I know she's been interested for a while. This is the thing. You guys, as Sage, as one of our leaders, you guys get all the help. Everyone gets all the help, but you guys definitely, I know she's been interested for a while. And we have, I should say, related to her thoughts, I believe we do have community violence as one of the top problems. I would say that my understanding is that it has not been consistently one of the top. It's been relatively rare, but we do have community violence as one of the possible health problems that people can indicate or demonstrate.
Okay.
So Paola, I do see, Paola Jimenez Munoz, I'm sorry, I'll say your whole name. I see that you are one of Dr. Guerrero's PhD students, and you're intrigued in the perceived need and investment across intervention types. So how are these questions framed, or what examples for lifestyle and neighborhood level interventions were given? I will highlight for lifestyle, definitely, probably, I should pull it up actually. I'll share them with you so I keep myself honest, right? I do know that we often use exercise and diet around lifestyle pieces. And then in terms of neighborhood level interventions, we were mostly framing that around like community level interventions, but I don't know that we gave beautiful examples for it. It's definitely something that we need to work on in the future. But I'm happy to share the instrument with you so you can actually see it.
That would be amazing. Thank you.
Yeah. Just email me, because all bets are off with my memory. My memory is low. The heart is willing, the brain is weak. Cool. I also want to give a shout out to Dr. Surya Lofton, who's here. She's like, oh no, Yami called my name. But Surya Lofton was our community outreach and engagement liaison for cancer prevention and control until a few months ago. And she helped shape our 2023 data as well. So just to your earlier question, Jeanette, Surya, Lisa Tussing Humphreys, Sage Kim, as well as Marion were our cancer prevention control partners
Great.
in terms of figuring out the questions.
Great, thanks, Yami.
But I will also note community partners included, because it was not all UIC folks who picked the response questions. So there's that. I will also, I will ask for your grace for a minute, but we did publish on our community health needs assessment last year. So I will ask for your grace for 1 second while I pull it up and put it in the chat.
And while Yami's pulling that up, I just want to remind everyone that this presentation will be recorded, and we're going to make sure and make it available to folks who registered but were unable to attend today. And we encourage you to share it within your networks, and if you know someone who might wasn't able to attend but would be interested, please send them Dr. Molina's way. Really, I think the goal here is to do something with this information, and it does nothing for us just to say we collected it. There's a lot of really rich information in here, actionable information that could set the stage for something, you know, bigger. And that's what we really want to do. Is we have it here, we have folks that are willing to help develop, you know, these projects, and so we can first start among many to kind of, you know, make change, have impact. So please share everything that you heard, and again, we'll make sure that things are available for folks who weren't able to join today. Sorry, Yami, I was just filling in what you.
Yeah, and I'm happy to answer any questions, but also if we need 10 minutes before we hit the other Zoom calls that I'm sure we're multitasking on, I'm totally good with it. I think the end all, and thank you so much. Thank you so much, Heather, for hosting us and giving this. Things to remember: one, we do this once a semester, so we'll have a fall one where I'll re-talk about service grants and opportunities to work with us on funding projects. And then we will also have opportunities to talk about what 2025 looked like in terms of our needs assessment, probably for next spring. So we have data. We also have projects. If you're more of an interventionist who would like to connect around what interventions and service projects we want to do, I will not say we have all the money in the world, but we have what we have. And we are good sharers in so many ways. And just to reiterate a point that Heather made just early on, just, you know, I think many of us are community centric and community focused. And so secondary analyses can and should be useful for community members. And so any ways that we can use their data that they have offered to us so generously are great, especially, again, advocating what they prioritize. Because so often we focus on what people have, not on what people think we should do. So this is an excellent opportunity for us to really listen to them and put it out to as many folks as we can. Awesome. Thank you all.
Thank you so much.
Okay. Bye-bye. Have a great
Bye.
day.
Bye.